Good afternoon, and welcome to the last in our webinar series focusing on effective electronic patient record implementations. Today we're going to be talking about interoperability and system integration. It's great to welcome so many of you here. We have over 120 registrants for this afternoon's webinar from all over the world. I think it shows what an important topic this is for health systems across the globe. My name is Frances Cousins, and I am a partner in healthcare technology in the Deloitte UK practice. Today, as I said, we're going to be talking about interoperability and system integration. And on the next slide, you can see how this fits into our overview of the series. So thank you to those of you who've joined every single one of these webinars. And if you're new today, you're very welcome. The purpose of the webinar series really is to focus on the effective partnerships necessary to succeed in technology implementations. Now, to date, we have focused specifically on EPR implementations, but today we're going to be broadening our focus and looking at the challenges and opportunities of interoperability in a world of increasing health system integration. We'll be highlighting the common pitfalls faced in our experience as professionals and also in our projects with our clients, and addressing some of the key strategies necessary for addressing those pitfalls to achieve the aims that we're all focusing on. And that is to develop our healthcare practice, better quality outcomes for our patients through the use of technology and data. So I'm now going to hand to my colleague Mark to introduce our panel for today.
Great, thank you, Fran. I appreciate the introduction. Good afternoon, everybody. Mark Perlman. I'm a partner out of the United States, and I also have the pleasure of serving as our global digital care leader. Today, we have a great session as to conclude our seventh series featuring Tony Jurek and Mike Morrison. To introduce Tony, a longstanding friend of mine, Tony's a managing director also in the United States and spends his time with health plans and providers. He's been with Deloitte since 2011 and currently leads our interoperability and standards practice in the US. He also works globally with many other clients. His responsibilities include the oversight of the development of Deloitte's technology planning and implementation frameworks, including integrated health and population health management systems, health information exchanges, and EMR, EPR systems. It's great to have Tony join us today. And Tony, thanks for coming off of your holiday for 3 minutes to help us here. Joining Tony will be Mike Morrison, who's a leader in our Canadian practice. And he also is the delivery lead for Canada's interoperability solutions. Mike has been with Deloitte for over 7 years, and he started his career as a respiratory therapist, working for over 10 years and decided to change careers and come over to technology. Mike has worked in healthcare technology with a focus on interoperability for the last 20 years. Next slide. So the agenda we'll be talking about today is certainly what is interoperability? What does it really mean so that we can look within the context of the EPR and where we're going as health systems and NHS trust? But also, why do we interoperate? What are we going to look to accomplish? And really, ultimately, when we do, what are the benefits we can achieve? And finally, what are some pragmatic ways and some things we need to think about or lessons learned as you look to take this journey? We'll certainly go through our question and answer time, so feel free to put those comments in the text box and bring the questions forward, and then we'll summarize together at the end. Again, I want to thank our team who spent countless hours bringing this beautiful series together, and really do appreciate the great effort of you guys to take the time, our clients and our friends, to join us for these series. Fran?
Thanks, Mark. So those of you who've joined other webinars will now be familiar with this slide. The reason that we bring it to each webinar is that it's so important to have effective foundations in any technology program, foundations that set out the governance, the guiding principles, and enable programs and projects to make effective decisions. So you can see here that we establish through the pyramid the layers of groups of individuals who both report on program status, but also take those decisions and how those decisions should be taken at each layer of the pyramid. We're going to talk now in the specific context of interoperability and system integration about the guiding principles that we believe should inform the governance of a program of this nature. And I'll hand to Tony to do that.
Thanks, Fran. Hello, everybody. I'm glad to be here with you today. As Fran has stated, we want to focus a little bit on the guiding principles. And to start this off, one of the things that I get asked very frequently as I lay out these strategies and architectures is where to start. Primarily, having a framework just simply around the decisions and the guiding principles of interoperability is going to serve and has served my clients and will serve you well to have in place. The interesting thing is the guiding principles of interoperability have been really technology focused, and they must evolve to support the maturing of this industry to a truly open and interoperable system of care. To understand what I mean, I want to talk a little bit about both the old versus the new guiding principles of implementing these types of environments and solutions. In the US here, we have an organization called the Office of National Coordination, or ONC, and they laid out strategies. I'm sure as we talk globally, each one of you have something similar in play in your organizations or your countries, excuse me. These old principles, at least here, were focused on the technology aspects of interoperability, in which it outlines these principles for what the platform needs to look like, what the technology needs to look like, but not necessarily what the business side of everything needs to look like to support it. These principles are logical, they're highly applicable, and in fact, they mirror a lot of what we recommend from a strategy perspective. We'd like to say, leverage what you have, buy what you need, build if you must. But they don't actually do enough to guide decisions necessary to enable a truly open and interoperable environment. And for the most part, these principles are focused on the technology aspects, like I said earlier. They were adequate when it was really just about meeting minimum requirements, at least in the States here. And I'm sure there's some other types of situations you've all lived through as well. We call this the kind of the norm, the checking the box. But what has really now needed for these guiding principles, which you see on the right here, is decision-making principles that go well beyond the norm. These new principles are focused on the clinical, operational, and administration aspects of interoperability. And looking across the stakeholders of healthcare, each have specific needs. Physicians need access to diagnosis and treatments and treatment data to make clinical decisions. Leaders in operations need to determine how procedures followed in providing clinical care can reduce safety risks and improve quality of care. And CFOs need to assess how much clinical and operational interactions and associated decisions can affect the financial health of the system. These are all business-driven perspectives that are really required to drive what is, again, truly interoperable systems and networks of care. With that, I'll pass it back, and if you can go to the next slide, please. The term interoperability continues to be a catch-all, by the way, for anything involving the movement of health information between more endpoints. Your system, your health systems, the organizations within those systems, across clinics, across types of stakeholders. The actual services delivered in this movement are, however, rarely considered, let alone the value they deliver. Information sharing and consolidation are just the tip of the iceberg to the broad span of potentially value-added services. Think electronic referrals, electronic prior authorizations, care plan collaborations, things like that. This is not just about data sharing, but also workflow enablement. Again, going back to these guiding principles that focus on clinical, operational, and administrative needs. The definition of interoperability should be broader. Interoperability is the capability to bring all relevant data, information to the points of care in near real time and to connect workflows to help facilitate the interactions. It's also based on looking at interoperability from 4 levels of data and information and workflow access. Give you a couple of examples. At the data level, if you think of your EPR environments, the Epics, the Cerners, Allscripts, they operate on a single data model, data platform that all functional aspects of their capabilities link to. That's a data level interop approach. It's one that's worked for this industry up until now. But now we have to focus on these other 3 and bringing together application level. This is the API conversation, FHIR, HL7, X12 data exchange, things like that. User experience is that bringing together functionality and data and workflow via portals and other types of web-based experiences. And then, of course, the workflow. If you think about workflow interoperability, there are standards for doing that so that you can track and monitor the state, if you will, of a care collaboration where a patient or a person or consumer is in the network of care and what types of services they've received. There are standards like BPEL, the business process engineering language, which is built just specifically for sharing workflow related metadata so you can track and manage things like that. So as you can see from what we present here, the interoperability is critical, is a critical barrier to overcome the needs of the empowered healthcare consumer. It's also bringing all the relevant information to all points of care and connecting workflows through the healthcare continuum. Next slide. Putting the patient at the center of care cannot be interpreted either literally, i.e. the patient's care and associated data always flows through the patient themselves, or figuratively. Every interaction associated with a patient's care is focused on what's best for the patient, not what's best for the provider or insurance, regardless if the patient is present or not. Interoperability is one of the 5 areas that we focus on in overall enterprise technology strategies that is really the foundation. It enables everything that goes on above it. In fact, if you look at this diagram, everything to the left of a column or a pillar requires what is going on in the previous pillars. Interoperability obviously being the core foundational capability that needs to be in place. And we believe effective management of care needs, demonstrable competency in these 5 technology areas are required. You also have to keep in mind, though, not everybody's at the same point or may not, and normally don't exist in every organization, which brings the following questions about interoperability. Is interoperability a service offered by the government, by health plans, in your case, in most cases, a single payer organization, by the providers themselves, or by independent organizations? We have something called eHealth Exchange here in the States. We also have a couple of other types of public related data information and workflow exchanges. Or is it done by a combination of all the above? By taking a service approach to interoperability, which is a core and as we talked about from a guiding principle, an essential event-driven message-centric approach to interoperability, the industry can negotiate and align around what's best for not just the patients, I take that back, but for all stakeholders, and decide who's best to provide the services or service and execute on agreed upon set of policies for delivering these services. Again, all of these are rules and aspects of the technologies implemented across all stakeholders, but interoperability becomes core to enabling that truly interoperable platform of care. Next slide.
All right, good afternoon, everyone. I'd like to talk a little bit about the history and evolution of interoperability. So the origin of health interoperability really started in the hospitals when they were sharing clinical documents between systems in a point-to-point manner. And this originally worked fine within the single system. Then the needs expanded to share data between facilities managed by hospital groups. And this is where we started to see some of the interoperability challenges we still see today. As we move beyond the borders of our hospital groups, things like patient identification and matching, data standards, and other supporting technologies become more and more complex. We are now dealing with event-driven, message-centric APIs and services compared to the document-centric platforms in the hospital settings. Interoperability solutions need to support not only the data exchange, but the network services, registries, large diverse stakeholder groups, and industry standards that are developed to solve some of the challenges we run into sharing clinical information. The volume of services and endpoints need to interact together are so large that traditional point-to-point approach is unmanageable. It's critical that you have a system that can implement these services in a way that not only shares the data, but provides required information for all stakeholders in the organization. Next slide, please. Today's interoperability platforms are limited. Our experience has been that they're designed to address the technical challenges of connecting between systems securely and sharing the data. But as you can see on the left side of this diagram, there are a number of distinct roles that are involved in exchanging clinical data above and beyond the technical team. At a high level, an interoperability process really starts from defining what we refer to as the health service. It could be a patient registration, a lab service, radiology service, or a notification service about a health event that has occurred. This is followed by defining the service requirements for all stakeholders, not just the technology stakeholders, as most interoperability systems are designed for today. Then the service is built out and tested, and once it's been approved, the onboarding team engages with the stakeholders that wish to consume the service. And this is where governance around these processes is crucial to onboard your stakeholders in an effective and timely manner. Once the stakeholders are onboarded, there are additional stakeholders that need to be able to assess the current state of the service. This is crucial for getting the full value out of the interoperability solution. Next slide. I'll pass it back to Fran.
Thanks, Mike. So we've talked about what interoperability is and its history and how it's evolved. But there are some forces in our health economy in the UK, and I'm sure in many others around the world, that are driving us towards data sharing and interoperability. Now, on this slide, we've looked at it from the UK perspective. Here we are making the transition to integrated care systems at the end of March next year, moving to a number of over 40 integrated care systems across England. And we're shifting our focus from a fee-for-service payment arrangement to value-based care. This is really because we recognise that our current way of reimbursement and the influence that that has on the way that we practice and behave in health systems is creating an unsustainable ecosystem. And what we need to do is to focus on delivering high quality, lower cost, sustainable care. And a key mechanism for that is to ensure that we are sharing all the information around our patients, their care, and their future care needs. So we want to expand those insights to understand new data sources, such as the social determinants of health and behavioural health, to gain a deeper insight into our patients and the needs that they may have, both now and in the future. And we are seeing a drive increasingly from our patients and from those who consume healthcare. They're used in other areas of their lives to see data on demand, both about what they want to consume and also about their own habits of consumption. So that demand will, I think, be an increasing factor in the drive towards interoperability over time. We've seen an amazing use of technology for the booking and resulting of COVID tests in a way that we haven't seen in the UK before. We're seeing the introduction and almost ubiquitous use of virtual healthcare in our general practice and in hospitals. This is generating a real drive from our patients for us to digitize our care processes and then generate data, which is really valuable in terms of planning and executing health systems into the future. And one evidence of that is that we are seeing some new entrants into the market, and those entrants will potentially significantly disrupt that market. Amazon, Google, Apple are all executing large-scale strategies for the curation and use of healthcare data. Now, clearly, there's a whole area of regulatory and ethical issues here, which we won't explore today, but these are important drivers from our wider society and the impact that they are having on our health system. We're making great strides at a national level to focus on sharing open data defined by core data standards. And these are really important building blocks to enable us to develop trusted exchange networks that exchange the right data in the right context around the right patient, and that will really help us drive the technical aspects and data aspects of our interoperability landscape. And lastly, we've seen the evolution of technology to wide-scale cloud computing, cognitive computing, machine learning, AI, etc. We are now on the edge of a new era of the use of data in our healthcare industry, and creating and curating larger data sets will enable us to leverage those capabilities and technologies more effectively. So you can see on the left there that our integrated care systems, driven by the strategic commissioning of care and enabled by a longitudinal healthcare record, are focusing on generating those data sets for and about our patients as they consume healthcare and as they live their journey of life. So there are a number of very significant forces that are driving us now in our data and digital strategies towards the era of interoperability.
As Fran talked about in the last slide, the idea of technology and the changes and new entrants are having a major impact on how the industry is moving towards a truly open interoperable platform or capability. In spite of these drastic changes in your current technology and the traditional technology foundations, new models of interoperability and healthcare solutions are being brought to this sector, or these sectors, if you will, payers, providers, life sciences, by many non-traditional organizations, as you see on the slide here. Cloud vendors bring computing power and capacity unmatched by the older transformation engines and that are used by the industry. These types of organizations have brought to life the business services needed to manage the interactions of healthcare stakeholders, as well as the technical services, finally, to allow the industry to move at the speed of industry change, which all agree is on its way, if not already here for a lot of us. Other vendors and providers of services like Expedia are developing new, and Uber are developing new and very sophisticated models for business where price transparency, access, affordability all reign supreme as part of the platform that hunts down drivers or hunts down pricing and price variations across multiple providers of whatever services, in Expedia's case, hotels and air travel, things like that. And in the States here, there is a big push towards that kind of price transparency to find the prices for care delivery services across the broad range of hospitals, clinics, and specialties. Some of the other areas of new entrants that are really exerting pressure are things like the Netflix experience and how they're changing our views and use of entertainment media. Let's face it, guys, I don't go to movie theaters anymore. I don't think a lot of people do in the States here, because you can see the same thing online via either a Netflix or other kind of services at the exact same time. The bottom line of regulatory change and the other factors that Fran talked about, new entrants into healthcare, are driving consumers of that healthcare to demand even more quality, more affordability, better access, and a much improved experience as they're interacting with others providing care services. Next slide.
So I'd like to talk a little bit about the interoperability technology maturity framework we've laid out. So because of the start and end points, as well as business models and goals are different for every organization, there really is no one-size-fits-all solution. Interoperability requires a varying combination of integration, data management, security, administration, and innovation to unify information access and integrate with workflows effectively. This is where interoperability projects are often underestimated. People generally understand the integration component of exchanging the data from endpoint to endpoint, but the administration, security, and data management aspects are often overlooked. As you can see on the slide, there are many processes that come into play, and as the complexity and maturity of the interoperability needs grow, there are more processes that need to be included and managed. Basic interoperability requirements can be met with foundational and developed components, but as the complexity and maturity of the services grows, it's important to work with a partner that has experience with more advanced capabilities, and that can be your innovation partner. Organizations make significant investments into these interoperability solutions, but our experience has been they don't always realize the value they expected because of some of these things that get overlooked. Next slide, please. It's really important to understand the organization's interoperability capabilities before defining the services that they're going to be implemented. It's a journey to move from that basic information sharing capabilities to more complex capabilities like collaborative care and decision support. The organization needs to be structured properly to get the full value out of the services created. If the people and processes are not in place, it doesn't matter really how good the tech is. You won't get the full value out of the service. We've seen time and time again where the organization wasn't ready to support those new capabilities, and that's where those projects generally fail. This is where it's important to have a partner that can support more than just implementing the technology, but support through the business transformation journey as well. Next slide, please. The maturity model provides a general model on the layering order of interoperability data capabilities across the development of an EPR. Organizations typically start with the foundational clinical components seen here, followed by more enhanced services. As organizations mature, additional business integration capabilities are required, and your interoperability solution needs to be able to support both the clinical integration and the business integration services. This is where it's critical to have a partner that both understands your environment and has the capability to innovate together with you. Next slide, please. Next slide. I'm not sure if that's moved on for others. It seems to be hung for me. Oh, there it goes. Yeah, so what to implement? Technology considerations. So most organizations start with selecting an interoperability solution to exchange information within their own organization. Most tech solutions manage these requirements quite well. The challenge comes when interacting outside of your organization. These interoperability technologies can be distributed and overlapping, and this can create a number of challenges if proper governance is not established between the service providers. An interoperability solution architecture can be broken down into the 4 key services. They're infrastructure services, so things like audit logging, monitoring, business rules, security management, messaging, and exception handling. And then data services, that's where data warehouse, business intelligence, audit and logging data, decision support, messaging data, and medical management come into play. Distributed services, so master patient index, consent management, alerts, electronic patient record, record locator services, terminology, identity management, and EPR Lite. And finally, business services. So we talk about demographics, e-prescribing and medications, immunizations, lab order results, disease admit, visit and discharge notes, allergies, radiology, DI, and scheduling all come into play. And each of these key areas are needed to be addressed when defining and implementing a new service. And it's important to address the organizational changes needed to support these going forward. Next slide, please. So the system integration strategy, the goal in developing an integration strategy is to work toward a fully integrated solution that meet the needs of all stakeholders. So as you can see on the slide, the architecture required to reach this goal changes as additional stakeholders are introduced. It's important that the interoperability solution that you choose is able to grow with your needs. As you move from a single system to multiple instances within your organization, your interoperability solution needs to grow with you. Organizations often start with a simple integration engine, but they quickly grow into the need for registries, aggregate viewers, and more complex interfaces. And as you move beyond your organization, your interoperability solution will not only require additional capabilities such as consent management, vocabulary services, patient validation services, and so on, but there are a number of standards that you need to understand to be able to implement and meet your goals, such as cross-enterprise document sharing, cross-community access sharing, and the like. And next slide. So how do we tackle this? So our general process that we've developed, we have what we refer to as our health service catalog as part of our interoperability solution. And we use this as an accelerator when gathering requirements. It's been built based on years of defining health services for a number of our clients. And each service definition contains a number of items. So the first is the overview. So it sort of defines the purpose of the service. We define the roles and responsibilities. So who are our stakeholders and what are their key responsibilities within the service? We look at the key performance indicators. So what needs to be measured, the objective of the measurements, and the audience that's interested in those results. And then we get into the business rules. So we define the business requirements that must be met by the service. And we also define the process. So we document the description of the functional and non-functional requirements for each step. So we can integrate that in with the workflow. And then finally, we define the configuration. So this is where we define how the service is supposed to flow, all of the policies or business steps required to be configured to meet the needs. And from here, we architect the service and finalize mapping specs based on requirements like HL7, fire, and the like. And then we create the service level agreements for the health services. So this is sort of where we define what the service is all about. And then we add the policies that define the actions that will occur as part of that service. And that's our base. And from that base service, we then build for any exceptions that we have to define for any of the stakeholders we're working with that can't meet the default settings and configuration that were defined for that particular service. Next slide, please. So in dealing with the complexity of healthcare interoperability, this is where we often find that when you go beyond just a small number of integrations, you get into the need to manage them much more closely. You can't simply look at these point-to-point solutions when you start to have a large number of stakeholders. So our approach to dealing with this is to define the base and then manage by exception. So we start by defining the services as I previously described, and then we model out the organization into groups, things like hospitals, clinics, physician offices, and so on. And for each of these organizations, we identify the services that are required for each group. So hospitals would have a different set of services that they would be interested in from an integration perspective compared to a physician office and so on. And that's the starting point. And then we determine within these organizations where the exceptions are. And then we have to manage those. So those exceptions can be by group. So for example, if there's a group of hospitals that run their lab services differently than everybody else, or have a specific requirement based on their systems they use, or it could be at the individual location, such as a specific clinic just doesn't have the capability to do implement the service as defined in our default settings. And this allows the majority of stakeholders to run as per the default configuration, and those that require something different to use the new policies that we would create to address those exceptions. And this simplifies the overall management of the interoperability solution. And it also provides us the ability to identify where variances are and work with those organizations over the long term towards standardization. So with that, I'll hand it back to Tony.
We talked about several layers, moving from the technical ability to a function or a focus around business and organizational dynamics, if you will, required to make interoperability truly successful. Moving from technical to business focused, it's still important to remember that becoming truly interoperable is not without some big risks, which must be successfully mitigated to foster an environment favorable to all the things we've talked about today. Increased security and privacy risk from devices to wide range networks all connected together increases, of course, the risk of both data incidents and data breaches, as data is being pushed out to, in an IoT sense, to mobile devices and other monitoring devices. And as users or consumers or patients bring their own devices to their care, being able to dynamically handle the security policies and privacy policies with these truly mobile devices and wide area networks is critical to make sure the right level of not just the tools that are in place, but we have also found without the right monitoring, without the right reaction teams or tiger teams to deal with security and privacy risk, as well as looking at some of these other areas that could bring risk, like virtualization strategies and use of the cloud. We're seeing a lot of attacks, if you will, a lot of new viruses, a lot of things that people are trying to do that are nefarious and actually are looking to take the data from those solutions. So we, as interoperability platforms, have to, again, be far better at actively monitoring the real-time nature of interoperability, and to be able to provide not just reactionary, but preventative measures to keep that information safe and secure. Some of the other risks that we're seeing around cost of compliance, how many resources in terms of time and money are required by your organization to simply comply with new regulations, which introduce new challenges, and in a lot of cases, not necessarily thought through challenges or thought out challenges, as at least in the US here, we have a tendency to want to let the industry figure it out as they try to figure out not just the technology, but business solutions. The provider leaders are contributing valuable time in attempting to align state, local, federal standards across organizations, and it takes focus away from creating a better, more differentiated care delivery. Also, cost of compliance may mean moving into new partnerships with distributors, valuable solutions, but may not necessarily out of the box be aligned to everything from, as Mike talked about, variations in and exceptions in the processes. Much room for improvement still remains around not just managing these new relationships, new regulations, but also in the alignment to mitigate these risks, which in and of themselves have a time and resource requirement. One thing we also see from a risk standpoint is the rise of technical debt. Trade-offs between immature code, a code that doesn't quite work the way it's supposed to, leads to a certain level of technical debt. I would also argue that the technical focus of interoperability solutions today, i.e., as Mike talked about, the document-centric approach, has led to a platform of technologies that quite honestly aren't and haven't been designed to interact with other more sophisticated technologies, EFBs and mesh-centric type of platforms like a MuleSoft or an Infor or an IBM WebSphere, just to name a few. These technical debt risks can accrue because bad or inadequate or inexperienced architecture decisions. So focusing more on the quality and transparency of IT costs and operations allows these architects and or decision makers in the IT alongside their business counterparts to really implement a truly interoperable platform. These are not insurmountable risks, but they must be successfully mitigated to foster this environment of favorable interoperability across these dimensions, if you will. Next slide. Deloitte's experience around the globe includes implementing interoperability platforms at large health systems, at states, provincial administrations, and actually at a national level as well, on all the variations in the regulations that go along with the dynamic nature of the different levels of healthcare. Some of the lessons learned is included here from some of the projects that we've implemented over the years. As Mike said, we've been doing this a long time. Quality and consistency of data there's a lot of variability. We've had customers who want 100% exception-based designs. We've had customers who can leverage the standards effectively and require only maybe a 10 to 20% variation. But the variation of the data, regardless of how much it is, still has to be dealt with. There's rarely consistent data in terms of things like ADTs and other HL7 transactions. Even in fire, by the way, folks, fire is while closer to a standards standard that can be followed. The reality is at least I'm seeing a lot of resource success other than resource standard usage. So data quality and area that will need to be a foremost of any team. And as Mike talked about, the front end of the requirements and design work that needs to be done. Data fluidity is also an issue that we have come across. It allows for some data available in some systems, but not the data as an exchange capability, or as opposed to a shared fluid type of capability. It's really more partial today, and as we look at moving more towards true interoperability, it does need to include the broader explanation or applications of workflows and other interaction tools. A lot of cases, by the way, we see in the technology solutions today, the use of fire as a technical standard. What do I mean by that? Some clients are using fire as a pure standard, but across all dimensions of their business. And quite honest, fire was developed for clinical data exchange across the disparate systems that can support it, first and foremost. I've seen, and we've seen clients and customers building solutions soup to nuts, from user experience to ODS and other types of capabilities. Once again, not built for entire enterprise, about creating a massive exception framework around it. So within fire, exceptions aren't carried over by version, neither are the standards that are built into a version. So need to be aware of a lot of these technology solution differences, as well as how they're being used. And as I said earlier, direction it's going to be not for now, but for future as it comes up. There's also a couple of other areas we've seen both the EPR implementation standpoint as it relates to data exchange, as well as leveraging external tools to do data exchange. So these kind of lessons learned, while important, are not really as impactful to the cost and duration of implementing an interoperable solution as the three I talked about. Next slide. So where to get started? This is motherhood and apple pie for much everybody. However, there is a specific way of handling the vision and current state of interoperability that that is required in order to truly get from what is happening today, which to what needs to happen in real time, which is event-driven, message-centric. Understanding the events that need to trigger, if you will, a range of data. Understanding the scope of the data that will be exchanged. In other words, do you have an organization or something more sophisticated along a community active with deduplication, things like that. And then you have to, once you know what that vision is and how you want to handle interoperability, assessing the current state becomes a different exercise as well, because you're not looking at it as more of what you have, but more from a capability in what you have perspective as it relates to that that vision. And after that, again, as you look to implement the next generation, if you will, of interoperability solutions, you have to get ready. You have to prioritize the initiatives, pick use cases, and develop or implement based on a use case driven approach, rather than trying to build a complete foundation that will continue to evolve anyway, and not generate the value upfront that is needed to bring the rest of the organization along. With that, I'll pass it back to Fran and have her facilitate a bit of a Q&A with us.
Thanks, Tony, very much. It's been great to hear about the science and the art of interoperability, as we say, keeping the patient at the centre And thank you for all your questions coming through the chat. If there are any more, please do drop them in. I'd like to start first to Mike for a question about your experience of interoperability. And maybe you could tell us about an integration or interoperable service that you have implemented that you believe has been really impactful for patients. Perhaps give us an example of something you've been proud to be involved in.
Yeah, so one of the projects that I managed here in the province of Brunswick in Canada was the implementation of what we refer to as our drug information system. It was an integration project where we have connected all of the pharmacies out in the community centrally to our solution. So if I go to one of my pharmacies down the street and have a medication dispensed, then that record is sent centrally. And so if for some reason I show up in the emergency department and I'm unable to communicate with the other clinicians, they have the ability to go in and look up to see what medications I'm currently taking, along with other information from different projects that we've done. But for me, that one was really important, because you think of how it's a very clear path to a way of saving someone's life, to have that information and not make those critical mistakes because of a lack of knowledge of what a patient is taking. So for me, that one was very easy to get up in the morning and go to work hard on because it was so impactful to my community, and I really was excited about that project.
Thanks, Mike. So we've got another question here about identity and access management. So obviously in this world, we are introducing a number of different user groups, user sets, including the patients themselves. Mike, again, could you tell us about what you've observed in effective implementations that manage identity and access effectively?
Yeah, so there's a number of factors to think about there, right? So we're starting right off from the very start of identity. So everyone thinks, well, that's just, I need a username. But the bigger issue there is not so much creating the username and passwords. It's about, how do I make sure that the person that is signing up is the individual they say they are? So you can't simply start with, please fill in this page of your information, and I will give you access to your clinical record. Someone needs to validate that you are the person that you say you are to start with. So that's a critical piece of the workflow that often sort of gets overlooked in the original planning and estimation. From there, it's really following the traditional path of least amount of access. So if you're going to protect that information, you need to make sure that the people that are accessing it only have access to what they need to do their job or function. And then from there, once you have sort of your defined identity and access management protocols, there's two key things that need to be done within your systems. One is a privacy impact assessment, where you validate that the system, when it's set up correctly, is giving people to the right information at the right time, and you can trust that the system's being used appropriately. And then the second thing is a threat risk assessment. So you need to run through and validate that the security, even though a lot of these systems have great ways of implementing security, you need to make sure that it's been done properly. So the threat risk assessment checks not only the configuration of the security, make sure that you're not susceptible to denial of service attacks and all those other technical concerns. But then the last thing is process. You need to make sure you have right processes in place to manage the security. So when someone leaves the organization, do you have a process to decommission their account, and things like that? So there's a number of different areas to keep in mind, but the key things there I find is that the privacy impact assessment and that threat risk assessment really is critical to making sure that you've done everything correctly.
Fantastic.
If
Thanks.
I could follow up a little bit from that. One of the things also to extend the access station is not just do you have access to the data that you're asking for, but have you been granted the consent by anybody delivering that data, which can vary by person in terms of what the consent of data sharing is. We have implemented consent management frameworks on top of solutions to make sure that extra step to make sure that not only are you able to access the data, but what data are you given permission to access, which is a bit above and beyond really the traditional access management frameworks that are in place today.
Yeah.
Absolutely. Yeah, no, very, very good point. And many of the regulations, particularly here in the European Union, are very consent-based philosophically. So really important to have that as part of the framework. We've got another question coming in here about the technologies that you mentioned, Tony, MuleSoft and others. You know, how, when you're in a position of responsibility at a system level, how do you make the right choice around those types of technologies? What capabilities within the technologies do you think are most important?
So, number one, that can handle scale and they actually work. I know that sounds a bit, I don't know, simplified, simplistic in nature, but the reality is as you look at the real-time aspects of interoperability, they're no longer these giant engines that we're using that handle CDI claims transactions and things like that. These are things that have to not only be available and be able to be up and running in 4 nines, we like to say, or 99.999% of the time, but also are able to handle the complex transformations that could happen with the exceptions or the variations that we talked about earlier. So as we look at these overall platforms for real time, there are various aspects of that you're all familiar with, and chances are you're working with today. Gateway technologies, for example, and how people or organizations are managed in and out of your transformation or interoperability platforms. Are the types of solutions that need to be highly flexible, scalable, but flexible. In other words, if you look at some of these solutions, what kind of security requirements are you going to apply to the gateway versus to the actual request for delivery of data and information? There's multiple layers.
I think we may have lost Tony there, so we'll move on to the next, and I think what will probably be the last question. So clearly, the complexity of managing integration and interoperable systems is significant. Mike, can you tell me from your work with many clients across Canada, the US, and other countries, what characteristics does a leader need to manage this complexity?
So I think first and foremost, planning ahead of time is critical. So as Tony was mentioning before, understanding your vision, what is it you're trying to achieve, making sure you've got the governance in place, and someone that can lead the change management aspect of this. Often, these projects are looked as technology projects, but the reality is there's significant change to those organizations as you roll this technology out. And there's a number of stakeholders above and beyond the tech team that need to be involved, need information so that they can get the full value out of these services. It's one thing to get the information flowing back and forth, but if the system is simply collecting the data and you're not leveraging it to its full potential, then the value really isn't recognized. So from our perspective, good solid technical people that know what they're doing, have experience in the implementation of these interoperabilities obviously is critical. But you can't underestimate the need for leadership in the business transformation aspects that interoperability bring to the table.
Great. Well, thank you, Mike, and thank you, Tony, for answering those questions. And the key role of clinical leaders and system leaders in delivering effective interoperable services and care pathways is absolutely rung through this whole webinar this afternoon. I'm sure that's a topic that we will all be returning to on many occasions in the next 5 years, particularly here in the UK, possibly even beyond that. So I'll hand now to Mark to just talk about other resources that might be available and of interest to you.
Great, thank you, Fran, and thank you, Mike and Tony, for the great presentation. What I wanted to introduce you to, if you're not familiar, is the Deloitte Center for Health Solutions. We have one in London, we have one in the United States also. The center is really the research arm for Deloitte's life science and healthcare practice, with the aim of really being a trusted source of relevant, timely, and actionable insights and emerging trends. So I would encourage you to look at it for creative thinking, robust research, industry experience, as well as perspectives that truly might help you think forward as you plan and navigate some very challenging waters ahead, and also some areas that will create great opportunities, such as consumerism. I would draw your attention to the Global Healthcare Outlook, which is quite insightful, as well as other things that are more relevant to your market. So thank you very much, Fran.
Thanks, Mark. And as I found when I was working in the NHS, and still do now, that looking across the globe, recognising not only that everybody experiences the same problems, but some people have found some really innovative solutions, is a very rewarding activity. So I'd like now to draw to a close our 7-part webinar series on effective EPR implementations. To thank particularly our panel today for their really insightful view on interoperability, and in fact, I think setting up, as we end this webinar series, a really exciting future for those of us in technology and digital and data leadership. If you would like to listen to any of the previous webinars, they're all on our webpage, which is noted here below, and we will be putting this webinar on that webpage in the next couple of days. I'd like to thank you all very much for joining. I hope you have found the webinar series of use to support you in that very important journey that we're all taking to enable effective patient care through digital and data capabilities. I'd like to wish you all a very good evening, and thank you again for joining. Good night.